Okay, probably Dr. Janevska can
Yes.
show.
Okay.
Okay, and you can put. Do you have a flash drive or? Excellent. Yeah.
I will be present the second case from cardiovascular center. He is a male, 77 years old, present with pulsating sensation in the abdomen and pain. Medical history for this patient is successfully isolated aneurysm of AAA and both common iliac artery 8 years ago with comorbidities atrial fibrillation, ischemic stroke, dyslipidemia, arterial hypertension. From ultrasound Doppler, stent graft in the aortoiliac segment with persistent blood flow in the aneurysm sac and progression of the diameter of the aneurysm. This is the result of CT aortography, late endoleak type 3 with progression on the disease with progression of the diameter of aneurysm sac from 55 to 64 millimeters. This is the result. And our therapeutic method is endovascular treatment of endoleak type 3. Our strategy is right brachial and right common femoral artery approach and implantation of endurant stent graft and the right common femoral artery. Finally, will be closed with closure device, Manta 14 French. Maybe Professor Petrov some comment for this is the next live case.
Hopefully we'll see soon what our colleagues will do, but in fact what are the possibilities? Of course surgery is possible, but it would be quite risky to go for surgery for such a patient. He's an elderly doctor, and in this situation what is the most straightforward approach is to make so telescoping technique, so to put in between the grafts the Y graft and the migrated distal graft to make another graft and to make connection, reconnect. In fact, we are going to reconnect the modules of the main graft and the migrated graft. This case is showing very well that in fact we don't treat the disease. We treat, in fact, the aneurysm, but the disease will continue. And in some cases, there is a natural distal growth of the vessels, and this distal growth of the vessels liberates space for migration of the distal graft. And like in this case, definitely in fact the graft migrated distally, and on such a way there was now there is a gap between the migrated endograft and the proximal part of the graft of the endovascularly treated patient. In fact, even during the first intervention, it was quite a challenging case because there is a proximal tortuosity as well, and in tortuous anatomy, it's quite demanding. It's quite demanding because during the implantation you have to pay attention to all the branches, because after the procedure is finished, the anatomy is straightened or tortuous again. So with the stiff wires, we are straightening the anatomy. It's true that it's easier to implant endovascular devices, but after removing the wires, the anatomy is restored. So all the tortuosities are coming back. And what does it mean? It means that the grafts have to be very flexible and kink resistant, because otherwise, in case of very big tortuosity, it's possible, in fact, even the kink appearing again, it can compress on the level of the angle, it can compress the stent graft and thrombose. So in this situation, it will be also a difficult situation. And the other thing is, like I said, after removing all the wires and devices, the graft can migrate in case the anatomy is restored again. And probably you can, Mitko, you can probably put on the screen are they ready in the cath lab? Are you ready? Ah, okay, excellent. We see you, and we see also the picture of the angio. Can you, Zoran, can you comment what you have done?
We can start for the approach. We going to the plan. We have 5 French brachial approach, and the plan B sheetless implant the endurance from the right femoral approach. But this is the one of the last patient with surgical approach, and we have so much
tissue
resistance for the put the 40 French, and for that we're going up sizing of the sheet. We're now going with 10 French.
Is the so-called, yeah. It's the upsizing. For example, 6 French, 8 French, 10 French, 12 French. So it's a stepwise approach. After surgery, there is a huge tissue resistance there because of the previous surgery, and in this situation, it's important to make a small cut, skin cut, in order to liberate the resistance, and to make this upsizing, stepwise upsizing of the sheets. Not to jump from 6 French to 12 French or 14, but to go step by step.
Yes, we see that I have any.
Still progress. Still there is a resistance there. We see. And
something very important. I changed the wire from the stork.
You have to put Lunderquist.
No, because I not have enough place for the Lunderquist, I take Advantage 0.35.
Okay, it's also a very good option. We have commented today that Advantage is a very good family of supportive wires. So we can. It's also possible to make upsizing of the wires. So we can go Advantage, and in case it's not successful on the Advantage, we can put catheter, whatever catheter, in order to interchange for another more supportive wire.
I'm inside on the artery, and now I put the catheter. Yes, and after they're dead with lasso, I'm try. To take the wire from the brachial approach.
Okay. Any comments?
Lasso.
So what we see now, I'm asking you, is this the wire from above, from the brachial approach?
Yes, and catheter from the femoral approach.
Okay, and
I'm waiting for the
lasso.
Yes.
And yes, and
it's very interesting thing. You can explain, Professor Petrov. We not use the catheter from the lasso. We always use, in most of the case, right?
Yes. Right Judkins.
coronary.
Yeah.
Yes.
We are using coronary right Judkins catheter 5 or 6 French because on such a way the catheter is steerable, so it's possible to change the direction of the catheter. Otherwise, the original catheter of the lasso is straight, so we don't have the possibility to make a direction, to change the direction. And the right Judkins is very well steerable on such a way we can expose the lasso in order to accept the wire. And now you are going to see the wire will be pushed from above in order to enter the lasso. And Dr. Stankov will catch the wire with the lasso and will externalize. And after this true technique, we are going to have wire from the arm that is externalized from the femoral artery on such a way the support will be huge. So it's possible to put catheter over the catheter, it's possible to put supportive wire, and finally to succeed to put a big sheet, and through the big sheet to make implantation of additional endurant stent graft. Is it Terumo, the upper wire?
I will take now advantage I have on the table.
Yeah.
It's the Terumo in
Yeah,
the
you
proximal
have.
part.
Yeah, I see. This is the tip of the catheter from above that is already
Yes.
inside the separated graft. This is excellent, and the
Yes.
advantage will go down and hopefully will reach the lasso, the snare.
Yes.
Excellent. Okay.
Yeah.
Yeah, it's push and pull, back and forth.
Now it's in the better position.
Yeah.
I take it.
Yeah, you see, do it slowly. It's very well seen that the wire is already inside the lasso. And now this is the moment of externalization. So Dr. Stankov, you see, is pulling. Did they separate it or?
Yes, separated. Give me the down.
But
You see the-
you can remove the sheet and yeah, exactly.
Yes.
Excellent, very good. You see the wire is already inside the femoral sheet. So now if even removing the sheet, the wire will be already outside of the body. So he will have access to the wire. And so now on this wire, this is the already externalized wire. It's a 300 centimeter advantage wire, very good supportive wire. And on such a way, he will have connection between the brachial through the aorta and through the femoral. So it's one wire from the brachial to the femoral. And it's a full connection and full control of the wire on both sides. The so-called through and through maneuver. It's through and through maneuver, and over this wire it will be positioned. He will position the upgrade of the sheets in order to have space. Yeah.
Now I have very good
Support.
Yes, because contra. Следила нагоре. You can see, and for that I take no Terumo, but advantage, remove the catheter. It's most important when you use this technique, it's necessary to all part of the wire in the body must be covered from the microcatheter or catheter because it's very dangerous.
Very good point. In fact, there is like a protective sleeve. So the catheter from above, it's playing the role of protective sleeve of the wire because the catheter is not aggressive, but the wire can cut. It really can cut tissues. So in order to protect the tissues in all this tortuous anatomy, because when we straighten in the anatomy and we move wire, the wire absolutely literally can cut, the wire can cut. And in order to avoid this, the catheter from above is playing the role of protective sleeve of the wire. And what do you...
Now I take the catheter from the lasso
yes.
to the cross from the prosthesis, going up of the main body.
Yeah, in order to put the Lunderquist.
Yes, to change the wire.
So now he's in fact over the true and true technique. He will put a catheter, in this case the catheter from the lasso, but it's possible to introduce any of the catheters, and after having access into the aortic arch, he will escalate Lunderquist wire that is the stiffest one possible, and with a very good flexible tip. But the main body of the Lunderquist is very supportive, and on the Lunderquist he will implant the additional Endurant
prepare the prosthesis.
endograft. Is this the Lunderquist?
Yes. Now.
Okay. You are going to see. You are going to see now how the Lunderquist will straighten the anatomy. Yes, follow.
Go up. Agora.
Follow. Excellent.
That's enough.
Across the aortic arch.
And now we put pigtail catheter from the brachial approach for the angio.
For angio. Yeah.
Yes, only for angio.
In fact, this is our usual approach. Always we have arm approach for angiography, for registration. And in some cases, like in this case, for some manipulation of wires and catheters from above. And of course, the implantations are done from the femoral because of the bigger sheath. How many French is the Endurant requiring? 14?
We're going sheetless.
Sheetless is 14.
Yes, 14.
Now what he will do, he is already a 14 French sheet inside the femoral?
Inside, yes. On the advantage, I put
the 14 French.
14 French, yes, without any problem.
It means
without any resistance.
With this up escalation of the sheets, now the hole into the skin and the artery is already 14 French. And because in order to reduce the size of the hole, we are using sheetless implantation. So now the stent graft will go without a sheet, with the delivery system. So we are putting the delivery system of the Endurant stent graft directly into the wire without sheet. Because already the hole is absolutely equal of the hole of the sheetless positioned system.
Now we're ready for the placement of the stent graft. Ще следиш отдолу.
If you allow me, I will open your presentation. I didn't see it, but I can guess what I will see, and I will explain several tips and tricks about. So you see, this is the. You see
we are on the place.
The journey. You saw the journey of the stent graft over the wire, and on such a way we are aiming landing zone proximal and distal. So the new stent has to land at enough extension in the proximal stent and in the distal stent in order to have, in fact, a position of stent in stent on both sides in order to centralize the flow. And you remember the huge endoleak, and it's possibly 2 centimeters inside the proximal and 2 centimeters inside the distal stent, more or less.
We now, from the point of point, it's on the perfect position, I think. Any comments?
It's excellent. I think that the gap is just in the middle of the new stent, so
Yes.
you can open it.
We have point from the minimal
Overlapping. There is a
overlapping.
point, there is a contrasting point showing us what is the minimum segment for overlapping. So in order to have good apposition, I mean good by length, not by diameter. The diameter is clear, it has to be oversized, and the stent that he is implanting is oversized in order to have good connection of the tissue, but also it's important to have good length of overlapping in order to... are you going to make a gentle post-dilation balloon?
Yes, it's a very good question. What do you think? It's necessary or the...
Yeah, you can. I would
Here
advise,
result?
as in other cases, to put the pigtail just above the free flow and to make an injection in a contralateral projection and to decide. In case there is a full interruption of the endoleak, it's you don't need post-dilation.
We are ready for the angio for the C result.
And you can, the pigtail is over there.
Yes.
Already, so you can inject and...
Моля ви, не дишайте, професора. Избърза. Не бързай, ти кажа. We try again.
Да диша.
Дишай. Професора каза да дишаш. За секунда не дишайте отново, професора.
Сега. I think it's quite good.
We don't see the iliac.
Please remember,
we don't not see endoleak.
It's the best way is to interchange with the 14 French sheet.
Yes, I do it now.
Yeah, to
but
make.
I think that everything is okay.
I think it's fine, and to make flow by the sheet in order to be sure that But I think you will not need ballooning. I can guess.
We see after 1 minute.
Iris, what do you think? Do you think we'll need post-dilation?
I would do it.
Yeah, Professor Matthias is suggesting a gentle ballooning.
Yes.
Okay, give me one Reliant.
Yeah, exactly. The Reliant is extremely compliant balloon. In fact, it's used not for dilation; it's used for molding, for positioning. Yeah.
Between the endografts to have a safe attachment.
Yes.
No fold or anything. So.
Okay, they are going to do a post-dilation, and finally they are going to imitate flow with some gentle suction from the sheet, and this will be really... In fact, it's a challenging situation because it's quite a big aneurysm, and for the iliac zone, it's a huge aneurysm. Yeah, over there, just at the edge of the new stent. After the balloon, I'm explaining the audience, after the balloon is becoming rectangular, it means it's enough. So we don't, it's enough there, and go inside the disconnected stent. In fact, this is the migrated stent, is this one that will be inflated now. Yes, excellent.
Yeah,
So
good.
because the balloon is spheric, the balloon is generally on the table will be spheric. In case the balloon is becoming rectangular, it means this is enough inflation. There is no need for more inflation. It means
Голяма
there is a
тя.
good touch between the balloon and the surface of the graft. Because of that,
Okay,
it's
we
becoming
are ready for the angio
so
to
it's
see the result.
because
Flow.
the tips and tricks session is on the other side, but we are showing here tips and tricks about restoring the flow because the sheet is occlusive for the common femoral. Now we're going to create flow through aspiration by the cutter. Go ahead.
Go, окей. Пръскай.
Да не диша.
Не дишайте, моля ви.
Aspirate. Slowly go. Aspirate. I think it's excellent. You see, even in the late phase, there is no feeling of the aneurysm.
Yes.
You can do it once again. With a little later, but faster aspiration by the sheet.
Yes. We remember the iliac, it's very,
And also a different angulation of the C-arm
yes.
might be helpful.
You can do
Now
some-
it's okay. I have the flow. Okay.
Yeah, that looks very good.
Wait. Excellent, it's enough. So why I'm asking he to wait? In order to see the late phase.
Yeah.
In some cases, there is a late endoleak that can be also problematic. But in this case, even in the late phase, after the contrast disappearing from the contralateral artery, there is no endoleak. So the almost venous phase, no endoleak. It's the same what our colleagues from imaging department doing during the examination of aneurysms, endoleak examination. Because of that, it's important to have late phase, not just to see, but to wait.
Добре си, нали? Добре сте.
What, Manta or Angiosio? Angiosio, I can guess.
Manta. No.
Manta. Because it's 14 French.
14.
I shared.
It's too much off-label to put angiosyl.
Yes.
on the 14.
You're right. And it's 14 French, and we are using up to 12.
Yes.
So,
I'm not change the wire.
yeah,
I'm going with Manta with stiff wire
absolutely.
to reduce.
We are still with you in order to see the implantation of the Manta and the final injection. In the final injection, we are going to see also the restoration of the flow and the result of the Manta closure device. So we are going to have two targets. We are going to
And
have
the external iliac artery for damage, for dissection.
Exactly.
We see.
Yeah, because there were quite much manipulations on this zone.
Yes.
Tortuosity and surgical tissue, connective tissue.
Колко беше? Пусни. Извадиме от тръбата. Благодаря.
So this is the Manta, the several steps of Manta closure.
Yes.
There is a first click, the red window.
Yes.
Yes, looks very good.
You see?
Successful, yes.
You see there is
And
zero.
I think they
zero.
removed the wire.
Yeah, you have to remove the wire, cut the suture, and
Чакай сега.
make a
Искам
final.
сега да илиаката.
You see there is almost practically immediate hemostasis, local. It's enough, not anymore, to maintain some access. Okay,
Махни всички увеличения.
great.
Всички увеличения махни. Okay. Let us see the iliac artery.
Yeah, without
And-
magnification, they are going to take a look to everything, to the aneurysmatic zone and the zone of vascular access.
Yes. Моля ви, професора, не дишайте.
Wait. Wait. It's very good. You can do one more, several centimeters more distally to the femoral.
Yes.
But I see most probably everything is fine.
Yes.
And with 5 milliliters of contrast more.
Дай 15 мл. And I replace the pigtail inside on the main body
Yeah, it's also a very good idea.
because now I lose contrast in the visceral and renal artery.
Yeah,
I think this position of the pigtail is
excellent.
another.
Yeah, the contrast density will be much better.
Okay. Моля ви, не дишайте, пръскай.
Amazing.
Дай ми тази каудалната, която не правихме. Не. Като паяк дето беше.
Let it be.
I want to be sure the
Contralateral,
iliac
yes.
artery.
Yes.
For the C external iliac artery.
For the hypogastric.
Yes. Готови?
Excellent. Very good.
Професоре, моля ви, не дишайте отново. Пръскай.
Very good.
I think that everything is okay.
In fact, it's not okay, it's perfect. Congratulations.
Thank you. Thank you, everybody.
You can appreciate the huge tortuosity. You see? It's a huge tortuosity. Together with surgical connective tissue there, it's a tough case. Okay, great job, Zorana.
Благодаря.
Okay. In fact, I can try to say several words about the endoleaks closure. Валери, what do you think? Окей, давайте с презентацията на доцент Станков ще се опитам да се ориентирам и да ви разкажа това, какво сме правили през годините при разни такива шантави случаи. Okay, switching to PowerPoint. And the crown of the session will be Iris with tips and tricks for stroke intervention. In fact, the biggest challenge and danger, and the most challenging, yes. Because we know, I'm speaking as a cardioangiologist, we speak quite often because we know how vulnerable are the brain vessels. They are nothing to do with the coronary and peripheral arteries, and how unforgiving is the brain. The heart can forgive many stupidities, but the brain cannot. So it's absolutely, remember forever, absolutely. Yeah. Sometimes we cardiologists, we put some air in the heart. In case you flush rapidly fast, it's going in 2 minutes. The patient has some pain in several minutes and it's gone. But in the brain, it could be a disaster, absolutely. Момчета? Okay, so we are going to proceed with another lecture. In the meantime, Professor Stankov will send his presentation, and I will try to explain some. So the next is yours, I think, here is or.